So it seems our event is now live, and I'd like to extend a very warm welcome to everyone and thank you for setting aside time to join our APMEN Tech Talk webinar today. It's our first one for 2023, and we'll be rolling out several of these APMEN Vector Control Working Group Tech Talks during the course of the year. Roughly at about monthly or every 6-week interval, we'll put on a tech talk. So I said APMEN Tech Talk webinar today. APMEN, as you may or may not know, is an acronym that stands for the Asia Pacific Malaria Elimination Network, and it's a not-for-profit organization with a mandate to support the malaria elimination objectives of its 22 member states across Asia Pacific. Our webinar today is going to focus on community issues, in particular those communities that are at chronic risk of malaria infection. And that generally means those people that live in rural villages or similar settings, often in association with rice fields and forests or plantations, at least here in Asia, and overwhelmingly of low income. It's these people that bear a disproportionate share of the overall malaria burden. So if these are the villages and the people that produce the vast majority of malaria cases, it makes absolute sense that these people should be involved in efforts to reduce malaria. And then the question becomes, what do we expect the people in these villages to do? And how realistic are we in these expectations of ours? And as I'll mention in a moment, we're very happy to have 3 top quality presenters to talk to us on this topic. And I'd like to thank them sincerely for their time and effort to put together their presentations and spend time with us sharing their experience. So thank you, Suparat, thank you, Jocelyn, and thank you, Bart. We'll therefore have 3 PowerPoint presentations back to back, and this will be followed by the usual question and answer session. Our audience members can submit written questions during the presentations. Please use the question box, not the chat box, please. And I'd like to suggest that you precede your question with the name of the particular panel member you would like to respond to your question. For example, Suparat, and then put your question, or whoever you think is, whoever you would like to respond to your particular question. And then right at the end, after the Q&A session, there's a very short poll. It's quick, 1 minute of your time, but it does help us, and I'd be grateful if you can just quickly tick the boxes in that short poll. Finally, please note that this webinar is being recorded and it'll be made available on the APMEN and ORIN websites within a day or so. And the details of these sites will be made available on your screens. Our first speaker is going to be Dr. Suparat Wanukunon, who's going to talk on the topic of why do we do community engagement? And Suparat is a lecturer in the Department of Social and Environmental Medicine, Faculty of Tropical Medicine here at Mahidol University in Thailand. She received a PhD at the School of Population Health, University of Queensland in Brisbane, Australia in 2003. Dr. Wanukunon has about 20 years of experience in conducting research in Papua New Guinea and in Thailand, in particular field research for monitoring and evaluation of health intervention projects among communities. After 19 years being lost outside Thailand, she's now returned home and she's been working at Mahidol University since 2018. Here in Thailand, she's worked with communities as part of malaria and dengue projects, mainly along the Thai-Myanmar border, So again, thank you, Suparat, for finding time to join us. We're grateful for that. And over to you.
Okay, thank you very much. Let me share the screen. Okay, I hope everyone see the screen.
Can you make it full screen, please, Suparat?
Yep, it's coming. Thank you very much for the nice introduction, Leo, and thanks for the organizer for having me to present actually, it's a question that people are asking. But yes, while we do the community engagement, I probably bring my experience to basically present to this talk. Not going to talk more about the theory or whatever, probably experience will be much better to present it. Let me give you the example. This is my first work when I returned to Thailand is we would like to looking at why malaria is so high in this province. This is Braack province, as you can see here, is located along the border between Thai and Myanmar. Braack province has a high number of malaria cases and always ranked #1, in the country. And there are the districts along the border here that all have malaria, but the highest caseload is actually turned out to be in here. They call Tha Song Yang, and we put the short name is TSY. So TSY or Tha Song Yang is the very rural and remote and mountainous area. 70% of the population are Karen ethnic and rely on the subsisting farming and hunting and gathering from the forest. So looking at the malaria cases, TSY actually looking at the number of cases actually been rising compared with the other district. So with that is valent from the disease control department. They need to do something. So what the action they actually do? The plan for the community-based malaria control intervention. So who are the stakeholders at that time? So the host is actually the Office of Disease Prevention and Control, which is in Region 2 now is in Phitsanulok province. In the Tha Song Yang district themselves, they have the community representative, all groups, all group, even the monk, the elderly group, the youth group, the women's group who are representation, the business and NGO, also related to all the malaria control program. We also have, they also have the sub-district administrative office of municipality, which is belong to the Minister of Interior, local hospital, health facility, patrol police, army, and also school, all come together to work on how they actually solve such a problem. They have the policy already from the Minister of Health, how we can actually conduct and respond and conduct the policy in the way that make the most effective in the local context. So they start working on that. They plan for 5-year project. And it's already seen the impact that actually the number of cases has been reducing. I don't claim that it's probably come from the committee, purely community engagement, that might be come from the other factor. But the community themselves, they see the lower number of cases. They actually have quite a huge impact into the community that they have, generate such a kind of confident, empowered community to go on with another project to help to improve the health in that community. So in 2014, this project has been submitted and received the United Nations Award, Public Service Award. So that was a very, very, very proud moment of all the people, all the stakeholders who work in such a project. So why we do the community engagement? For the complexity of the issue, like I showed you before, in any given community, where the conventional or traditional approach has been ineffective. Community engagement probably will be more helpful because they enable better understanding of the community need and aspiration and possible solution. So community engagement also become viable and necessary because it actually can see the problem clearer when you actually really go to talk to the people and get the idea what exactly the problem, because that's actually increase the visibility and better understanding of the issue. So in the meantime, the community also have their say, because this is the way that they actually empower community to have their say. The community can choose the priority and decide on the plan, contribute to the public decision. So basically, more or less, the community taking a front seat because they have the local knowledge. They understand the setting better, which work and which is not working. So the stakeholder, including the community, working side by side together to ensure that, actually this is really the community public decision that empower people. So the constructive relationship between community and the government actually has been developed in such a process. Then listen to the feedback when after all the discussion, because this is more or less what we listen is like we use the bottom-up approach to public decision making. In this way, yes, it takes a long time, get until people agree to each other. It's such a headache. How could I mobilize all people to, to get the opinion? Is opinions gonna work or something? This all come up with all the, people who would like to do the community engagement. But we actually is gonna go to that, because this way, one is successful, it's such a rewarding, because the program become locally relevant and acceptable. In the meantime, working together, building deeper and stronger and more trusting relationship between community and the government entity into the future, not just only this project, it's probably build a ripple effect into the other project too. Because communities start engaged from the beginning, the community, they see the benefit, they see the problem and they see the benefit, they see their voice has been listened and respected. So community are willing because, because the benefits, they can see it clearly because they work on it too. So this way is actually help to develop the self-reliance in the future, community solidarity and unity from the engaging the project can lead to a lot of the effective future activity. So in the meantime, by the end, that would be very, very nice. We lead to the improve the project with the effective outcome. And we build and sustain the cohesive community themselves, drive the social transformation and strengthening the democracy. Oh, sounds very, very good. Yeah, that's true. Community engagement, in short, is a process of engaging those affected by a particular problem in solving, mitigating that problem. The process is from simple outreach or to consultation, collaboration, and shared responsibility and leadership. It depends on, capacity and the background of the community, that how much they can contribute and share. So I just borrow this from the CDC website. You see that the level of community involvement, okay? So I wouldn't explain very much that there are some very simple involvement down until share the leadership of the involvement. Okay, in short, community engagement will help the program, any health program, with the time and resource effectiveness. Okay. In the meantime, they also contribute to greatly to the program sustainability, because in fact, people, in nature, people decide to get better, physically, socially, economically. When people see that this is the benefit that they're gonna get, they probably will be really, really ready and willing to actually engage. And in the meantime, listen to them, listen to the community, actually go a long way toward building the successful program. And in the meantime, this really truly representative of democracy. Okay, thank you very much. I hope I'm not going to go over time.
Super, wonderful presentation. Thank you so much for that. You know, a nice overview, short and punchy and effective, you know, to explain why we do community engagement, how we do it, and what are the advantages and benefits that come from that. So wonderful summary, given with your usual friendly and open and engaging style. It's wonderful to listen to you.
Thank you.
Thank you very much, Superat.
You're welcome.
Thank you for that. So as I said, we're going to save the questions for after all three speakers have given their presentations. And in the meantime, there have been a number of chats coming up, and it shows there's a spread of people all the way from India through Malaysia, Papua New Guinea, including Solomon Islands as well. So again, welcome to everyone, and to any latecomers, just to ask if you have questions, please pop them in the Q&A box, not the chat box, because we'll be monitoring the questions box, please. Next up is Jocelyn Newcomb, who's familiar to many of you already, and she's going to talk around the topic of what do communities want? Jocelyn has 27 years of experience helping private companies and non-profit organizations address malaria, nutrition, and other community health priorities in low and middle income countries. Currently based in Vietnam, Jocelyn leads public health programming through Swipe RX. I'm not quite sure if I'm pronouncing that correctly.
Perfect.
Wonderful. Jocelyn has worked extensively with product development partners and manufacturers to ensure community needs and preferences are actually incorporated into market introduction of new products. And her areas of expertise include social and behavior change communication, community engagement, and private sector engagement. So again, thank you for your time, Jocelyn. We look forward to your pearls of wisdom, and over to you. Thank you.
Thank you so much, Leo, and to all of the participants today. It's a great pleasure to be with all of you and to see so many people from across the world joining us. Many thanks for that. Can you see my screen?
Yes.
Yes,
indeed, and it is full screen, so please go ahead, Jocelyn.
Wonderful, wonderful. I just have to figure out how to close this little box so that I can see my screen as well. Whoops.
Take your time, no pressure.
Not sure how to close this. Let's see if I can just move it up there. Great. So, so wonderful. I have the pleasure of following Suparat, who has already covered most of the key points in my first slide here. So thank you to Suparat for clarifying and emphasizing for all of us why community engagement is so important for all of us working in malaria control and elimination, but also in other public health areas. And I just want to briefly note that, you know, it's been well established that working closely with communities is really fundamental for improving health outcomes, right? Whether we're focusing on vector-borne disease control or other health priorities, working with and through communities is a necessary and not necessarily sufficient, but certainly necessary approach. And that goes for initiatives that are focusing on generating informed demand as well as improving access to vector control products and related behaviors, regardless of the focus of our programming and research. Understanding the needs and preferences of communities at risk is the first step towards successful public health programming and research. So that's really important. Also important to note that there are substantial efficiency gains that can be leveraged from working through the private, public, and civil society channels that already serve communities at risk. And so again, as a really fundamental first step, it's important to understand what those channels are that are already reaching and engaging with the communities at risk, and ideally working through those, not exclusively, but working through the channels that are already serving communities at risk, as opposed to trying to set up separate vertical delivery channels, communication channels, or programming channels. And because of all these well-established reasons and benefits of engaging communities early and throughout the full project lifecycle for elimination and vector control programming, all of the major funders, bilateral and multilateral, strongly encourage the adoption of inclusive approaches and community engagement at all stages of programming. In addition, manufacturers and the product development partners that are working to introduce new vector control innovations to markets across the world are increasingly engaging communities earlier in the market introduction and market shaping process. So lots of great reasons why the topic that we're discussing today is so important and so impactful. And with that understanding, I thought that we would just walk through a few of the common myths about communities that have to date limited results, in case they may help all of us and the national malaria programs and other partners that those of you joining us today are working with to achieve better results in the future. So I'm going to go through a few slides summarizing some common misassumptions and then counter those misassumptions with what we know from the evidence and our experience, and briefly touch on some recommendations. So let's start with a very common misunderstanding, which is that communities have uniform needs and preferences. And I think I'm certainly preaching to the choir today. I know all of you have a wealth of experience with community engagement and designing, implementing, and evaluating vector-borne disease programs with communities, so this will not be new to you. However, there are still, program after program that make the mistake of neglecting the heterogeneity of perspectives that is important for any community that we're working with. And that heterogeneity of perspectives influences the type of vector control product that is and feasible and preferred. It influences the optimal delivery channels. It influences the type of behavior change messaging and communication channels that are appropriate. Almost every aspect of our programming ideally needs to be targeted to a specific segment of the community with shared perspectives and values. So one way of bringing this to life is to recognize that, for example, a grandmother who collects mushrooms in the forest in Mondulkiri will have a very different set of needs and preferences compared to a 17-year-old migrant living in a camp on the Thailand-Myanmar border. So just remembering that, age and gender and ethnicity and lots of other aspects of a day in the life of our target audience are very important to consider, and to respect the heterogeneity of perspectives that is inherently included in any community that we are working with. So the best way to counter this or prevent this risk is to conduct careful formative research to understand the needs of a specific target audience segment at risk, but with similar needs, values, and characteristics. And there are a number of resources related to each of the recommendations that we're going to cover today that the Vector Control Working Group would be happy to share with participants after today's session. Another common misassumption is that communities prefer to receive health products through public health channels. Given the previous point about the heterogeneity of any community at risk of malaria and other vector-borne diseases, it won't be surprising to any of us that communities are made up of a variety of different perspectives and profiles, right? So access preferences will also vary by product type and by audience segment. So again, referring back to the two examples from the previous slide, depending on whether my individual profile, if I'm a grandmother collecting mushrooms in Mondokiri, or if I'm a teenager in a migrant camp, those are very different situations, and we need to make sure that we are tailoring our access or our delivery mechanisms and channels based on the needs of all members of the community at risk, and recognize that there may be a variety of preferences. It's also important to note that that in all of the health systems and markets where we work, there is, by definition, these are mixed health systems with private as well as public, and in many cases, civil society channels already being accessed by communities at risk. So again, starting with the channels that are already accessed by our target audience and working through those, and perhaps multiple channels, private as well as public, is worth consideration. Another common misassumption is that communities are not able to pay for vector control products, and it's just important to emphasize that affordability is a critical part of access. So subsidies are certainly merited and justifiable. It's also important to understand that willingness to pay is a quite nuanced aspect of programming that deserves careful consideration and is likely to vary by type of product and also by audience segment. So we do know in several countries in Asia Pacific that individuals at risk, some individuals at risk of malaria and other vector-borne diseases are already purchasing vector control products or products that they think are effective at preventing mosquito bites. And we know in some cases they are spending money that they don't have on products that are not, certainly not WHO pre-qualified, that are not effective. So a great example of this is the untreated hammock gnat, which is quite common and is often purchased by communities at risk in the greater Mekong subregion, which indicates an opportunity to crowd the right products into private retail channels already serving communities at risk. And there's some great work being done in this area by IVCC and market research and other partners. So I think that that's really promising. Recommendations to prevent this risk is to make sure that we are targeting the subsidized product distribution for the most at risk community members who have the least willingness and ability to pay. So, this is especially as countries in Asia Pacific move toward elimination, the importance of making sure that we are not mass distributing vector control products that more than are needed, or in a way that does not align with the need, because that can also lead to market distortion. It can prevent sustainable contributions from manufacturers and other commercial partners, etc. And it can also negatively affect the value of donor-funded programming, including vector control product distribution. But secondly, really looking carefully at the product specifications of our vector control products and making sure that those product specifications align with the needs and preferences of communities at risk, so that we're delivering the products that communities want and need through multiple channels, including where appropriate, commercial market channels. And lastly, using market introduction or market shaping techniques in addition to subsidized public distribution to improve mixed health system or whole market access for communities to a range of products. Another misassumption is that communities will be motivated to use vector control products after they receive the essential information or education about the product. And again, I think this is a fairly well-known misassumption, and yet for whatever reason, it's one of the hardest myths to address, right? I think often in the public health community, we are rightly so very focused on the medical benefits of and health benefits of the products and the services and the behaviors that are so beneficial for communities. What we miss is that talking about the medical or the health benefits of those products doesn't always motivate behavior change. And I think a great thing to remember is that the whole world is aware and very knowledgeable about the fact that smoking cigarettes is harmful for our health, and yet millions of people continue to smoke. So thinking that simply explaining the health benefits of these products will motivate consistent and appropriate use is not necessarily going to be an effective strategy. There's quite a lot that has been demonstrated with evidence that really emphasizes the fact that behavior change and use of vector control products consistently and appropriately, and we should emphasize quality assured products. That is a behavior change challenge, and we know from the literature that behavior change requires using a behavior change framework to analyze social as well as individual barriers, and then using emotional as well as functional insights to design messaging that will motivate, that will go beyond informing to motivate the behavior that we're focusing on. And last but not least, and this I think links back to Suparat's presentation really nicely, we know that two-way engaging communication formats are particularly effective. We can't always rely on those exclusively, but where it's feasible to use two-way engaging formats of communication, those are highly recommended. So all of this is part of what we all know and love as social and behavior change communication. And one note to add here is that I think it's very important to be open-minded about the specific benefits that are recognized by communities with respect to vector control product use, but also other health behaviors. And time again, I've seen the public health community quite surprised to learn that it's actually the non-health benefits of a health product that resonate the most with the community. And the most important thing here is that when we're working to motivate communities to protect themselves with effective vector control products, what's important is what is important to them, right? And so understanding that and using those insights to inform our work is the recipe for success. Earlier today, I was meeting with the Project Bite team to discuss some of their research findings in Cambodia with respect to new vector control products that they are in the process of trialing with community feedback. And one of the most interesting findings in a culture where smell is very, very important was that the smell of the personal topical repellent product that they were trialing was viewed by the community members as so positive that they actually described one of the benefits of the use of that repellent product as related to the need for personal perfume. And some of the members of the community were saying, I love this product, smells so much. I want to use it when I go everywhere from my neighbor's wedding to my day-to-day business in the village and in the forest. So I think that's just one example, but a very clear reminder that we need to be cognizant of the reality that health is not always paramount and is not always the most critical motivational factor. So one thing that this raises, and I wanted to just touch on briefly, is many partners often talk about the difference between information, education, and communication, or social and behavior change communication. And so I thought I would share just a few guiding questions in case these are of use to all of us going forward. A quick checklist, and it's not designed to be exhaustive, but in case some of these questions can be helpful to you and your partners, it might be helpful to take a quick check on looking at your communication and your community engagement materials and ask, are we telling communities what to do? Or are we explaining the recommended practice in terms that emphasize the benefits that matter most to them, right? So getting outside of our conference rooms, being consistent with the medical guidance and understanding the medical and health benefits, but making sure that we're framing our messaging in terms that resonate with communities. Secondly, and related to that, are the messages and are the images designed to resonate with communities? And the photo here is a great example of some photos which reflect certain images of health workers and communities at risk, which may or may not resonate with the way that communities at risk see themselves. Do they see themselves as wearing that type of traditional dress? And there are a few other factors there that could be looked at quite carefully in the pre-testing. But also, let's not forget that we can continuously seek feedback from the communities that we work with, even after our materials are designed, so that we can continue to improve. Thirdly, are we facilitating two-way conversations? Are we lecturing or are we engaging? And fourth, are we leveraging the right channels, quote unquote, for a specific audience segment and message? And are we remembering that health messaging may or may not be most effectively delivered through health channels? So maybe it makes sense to think about engaging with forest goers at the small, fast-moving consumer goods, the small shop at the edge of the forest where he buys his cigarettes before he goes into the forest, for example. That's a non-health outlet, but it might make a lot of sense as a touch point for a vector control or other health campaigns. And lastly, are we understanding influencers in our communities, and are we leveraging peers as well as influencers as we design and think about the voices and the channels that we're using? Related to channels, just one final assumption, which is I think, we're all embracing technology and learning a lot about technology. The photo that I'm showing you here in this slide was taken in rural Cambodia, gosh, more than 3 years ago, in a very remote area close to the forest. And it was fascinating to see communities using their phones you can see she's actually built a stand for her phone, and she's using it for YouTube video watching. And really, the myth here is that communities won't be able to use mobile or digital solutions. I hear that, and I see that misunderstanding quite a bit in our work, even today. And I think that, the truth is that, again, we need to consider this on a case-by-case basis. And there's, we need to be careful not to generalize. And we also need to recognize that, technology before people doesn't work, and technology certainly can't address all of the vector control programming challenges. But understanding that and respecting the fact that access and feasibility will vary by on a case-by-case basis, the potential for mobile and digital solutions and channels is substantial, particularly in Asia Pacific, where connectivity is still not uniform, nor is it constant, but it is improving rapidly. And I think, you know, that the main point here is that the recommendation is not to make assumptions about what communities can and can't do, but to use a human-centered design approach to assessing the potential for community to benefit from digital solutions. And the Path Digital Square team, working in partnership with DVBD and the CSO platform, have done some really interesting recent work in Thailand, which I encourage all of you to learn more about if you are grappling with a similar issue in your program. Last but not least, there's also a common misunderstanding that communities need one vector control product option or maybe two. And I think we all understand as vector control professionals, if not champions, that choice is incredibly powerful. And we've seen, again, in the literature that choice within any product category in the public health space has been shown to increase uptake and use. And that has been well demonstrated for everything from contraceptives to HIV prevention mechanisms and many others. So the recommended approach in light of this truth is that, you know, we all need to support efforts to accelerate market and health system introduction of innovations in this space. And we can do that by ensuring that the regulatory pathway is transparent and is as short as possible for prioritized public health solutions, including vector control products that meet global quality standards. And secondly, by helping manufacturers, product development, and vector-borne disease programming and their partners, including community-based and community-focused civil society organizations, to plan introduction of innovations in this space. I want to close with an acknowledgement. First, a thank you to the APMEN Vector Control Working Group, but also to all of the partners listed here who have been an important part of the learnings that I've shared with you today. Many thanks to all of these partners for continuing to really innovate in the space of understanding and responding to the needs and preferences of communities at risk. Thank you so much.
Well, Jocelyn, thank you so much for those sharing those lessons learned through hard experience to make the rest of us, to remind us of certain misunderstandings, misapprehensions, and to help us become more effective in understanding what communities are receptive to, or more receptive to, and how to engage them more effectively and you know, get them to adopt what they want and they feel useful and meaningful. So wonderful overview there, and thank you for that, Jocelyn. Very helpful indeed.
My pleasure. Thank you, Leo.
Thank you, Jocelyn. So we're now going to move to our final speaker, which is Dr. Braack, who's well-known and highly respected figure in the world of malaria across the world. Bart is a graduate of Wageningen University in the Netherlands, where he obtained his PhD on malaria vector studies. Bart has spent many years in working in often very remote areas of Africa on tsetse flies, mostly on Anopheles mosquitoes, and mostly in Kenya, Tanzania, and Zambia. He completed his Master's in Business Administration, MBA, in 2006, and his particular energy, drive, and innovative thinking has resulted in many awards and international recognition. He's a pretty unique guy, this. Thinks differently to most of the rest of us and gets things done. So he's received many awards and recognition, including the IG Nobel Prize for his studies on the attraction of malaria mosquitoes to Limburger cheese volatiles, a field that I'm particularly interested in, and the APMEN medal, the highest award in the field of tropical medicine and international health in the Netherlands. He moved into a more commercial vector control career in 2007, set up a variety of different companies, including some that I'm sure many of us are aware of, such as Into Care, BV. And in 2010, together with his wife, Inge, they founded the Dutch Malaria Foundation. However, aside from Into Care, he and Inge are perhaps best known for the web platform Malaria World, which was born in late 2009 and now has almost 10,000 members in 140 countries. I can tell you that I get these Malaria World notices in my email inbox very regularly. I forget now, but it feels like every week I get a beautiful summary of content pages listing all the recent malaria-related publications that have appeared recently. So you should subscribe to it if you're not already on their subscription list. It's a really good source of information to get a short summary synopsis of in the world regarding publications on malaria-related issues. But is going to talk to us about community engagement for malaria elimination, its role and limitations. And, you know, this is an important reminder to all of us, you know, what is possible and what is not possible. So over to you, Bart, and thank you for your time.
Great. Thank you for putting the bar so high, straight from the start.
Yeah.
Let me start sharing my screen. Okay, there we go. All right. Well, hello, everyone, and thank you for the previous speakers. I would like to start off by thanking the organizers, and particularly you, Leo, for giving me an opportunity to share some of my views on community engagement in the context of malaria elimination. And I'm highlighting the word elimination. I'm not just talking about control, but specifically I will focus on elimination. And I will also focus primarily on the experiences that I've had in sub-Saharan Africa, although I believe that several of the points that I raised will also be useful for other parts of the world where people are working towards malaria elimination. So let me set the stage by asking a few questions. So the first thing that I'd like to do is I'd like to show you a picture of the village where I was born a long time ago in the south of the Netherlands. This is a picture from the late 19th century. And it is interesting because it shows you here in this image, the single largest contribution to public health in the history of Europe. On this slide, you can see the outcome of an intervention that has saved more lives than any other public health intervention in Europe. So maybe you see what it was, but this is what it was. It was the closure of the open sewage system. Human excrements, urine, no longer floating openly in the streets, but underground, protecting people from waterborne pathogens like cholera. So why is this interesting? Well, the people that you see in this image probably had no clue whatsoever about these diseases, about the causative agents, and the public health gains that would ensue from putting the systems underground. And besides that, I believe it's very unlikely that they actively participated in the construction of the underground sewage system. So the question is, do major public health gains always depend on community engagement? And I believe that the short answer in this case would be no. Next, I'm showing you the construction of the Aswan Dam in Egypt that was constructed between 1960 and 1976. And when finished, this hydroelectric power plant was sufficient to provide electricity to half the population of Egypt at the time. The question, does major development depend on community engagement? And again, I believe that this example is showing you that the answer would be no. People got light in their house, people got electricity sockets in their house, and that dramatically improved their living standards. And they did not bother, nor were they involved in any way actively in the construction of the dam. It was simply done for them. Next, look at primary school education. And one could ask the question, since most adults, you, me on this call, since most adults know how to read and write and do simple mathematics, why is there no community participation in our education system? And the answer, I believe, is very simple. Teachers have undergone training. They're professionals. They have mastered the didactic skills and they have acquired expertise in handling groups of children. Not all of us can do that. So do all activities themselves lend themselves to be part of community participation? And again, I believe that the answer here is no. Communities cannot teach classes of children. Communities cannot construct hydroelectric power plants. And communities cannot construct underground sewage systems. Managing development and improving public health can be taken care of by entities other than the communities themselves, even though at the end of the day, they are the main beneficiaries. And so this begs the question then, can communities control, and I believe in the context of this webinar, even more important, one step further, can communities eliminate vector-borne diseases, and more specifically, malaria? That's what we're going to be talking about. So let's go first back in history once more. At the time when the world embarked on the first global malaria eradication campaign, which ran between 1955 and 1969, how much responsibility was actually in the hands of communities in the more than, let's say, 80 countries at the time that succeeded with elimination? Or look at the example of the elimination of the yellow fever mosquito, Aedes aegypti, from an impressive 11 million square kilometers of South America between 1947 and 1962. Or look at the elimination of malaria from Egypt between 1943 and 1945. What part of these massive public health successes can actually be contributed to community engagement? And as it is, when you look at these old records, it was surprisingly little. By far the greatest contribution to elimination in countries that succeeded can be attributed to vertically staged programs in the hands of well-trained professionals, personnel that had paid jobs to do just that, to ensure successful elimination. So why then did we change this recipe for success? Why did the responsibility for control, let alone elimination, decentralize and got to rest in the hands of civilians? And the answer goes back to 1978. In that year, in 1978, the Alma-Ata conference was held in Russia, where governments from around the world convened, and they signed a declaration that emerged as a major milestone of the 20th century in the field of public health. It identified primary health care as the key to the attainment of the goal of health for all by the year 2000. And this made, of course, complete sense. Decentralization of healthcare to grassroots level would ensure care delivery to underprivileged communities in rural and remote parts of countries and save lives and improve physical, mental, and social well-being. However, and I believe that this is significant, in terms of vector-borne disease elimination, and I'm using the word again, elimination, this development, I believe, was disastrous. As far as I know, and I stand to be corrected here, there has not been elimination of a single vector-borne disease through community engagement only, with emphasis on the word only. And one could ask the question, why is that? To answer that question, we first need to look at what community engagement actually is. And the previous speakers have already given us some information on this. And a major issue, I believe, here is that within the global malaria community, us, two things prevail. First, we are using a lot of different terms indiscriminately to describe what we do with or alongside communities. And that is causing a lot of confusion. And secondly, it has become almost dogmatic, our belief that we can only move forward with malaria elimination if we do this through and with communities. And I'm convinced that if I would start arguing against community engagement in malaria elimination, that quite a few people in this webinar might get upset. So I'm not going to do that. There are different levels. There are different levels of community engagement. And I've borrowed this from Maxine, who I believe is actually on the call, which is nice, and Catherine Smith, who published this paper in 2015. And this shows you the different levels which we have when we go up towards more and more active participation of communities. What does this actually say? There's a lot of text here. You don't need to read all this. I will walk you through it. It goes simply from a community saying, "Go away. We don't want you here. We don't want what you're doing." That is a definite stop sign from a community that you may get. To, "Okay, go ahead. Go ahead. We're happy with what you want to do in our community." And normally this is preceded by something which we call community awareness or community education, people understanding what the whole idea is. And I believe a typical example of this is of community consent, people saying go ahead, is that people open up their doors and they let the spray people come in and they let their house being sprayed with some chemical, indoor residual spraying. So a step up from this is compliance. We go and we actually do it. We help the good cause. We help the good cause that you're trying to do for us. And in this case, it's community compliance, which a good example would be people sleeping every night under insecticide-treated bed net. A small contribution to making a program a success. A step up from this would be active participation. People are now going for it. You're asking a lot more from community members in terms of their participation in your efforts to eliminate a vector-borne disease. People have to do things more seriously, and I would classify this as true community participation. There are some good examples of this. We're asking pregnant women during their pregnancy to visit antenatal clinics every once in a while to go for treatment, the intermittent preventive treatment. We're asking people to take part in seasonal malaria chemo prevention. They have to bring their children to certain points to get medication. We do mass drug administration programs. We have active case detection through surveillance programs. And sure enough, in future, there will be this thing where mothers will have to bring their children to clinics to get 4 shots with Mosquirix, with the RTSS vaccine. So that is certainly one step up. And then the highest level that we can attain in our community participation is for them to actually go and lead or co-lead it with other entities. This is now community ownership. The community themselves drive the entire program. They are heavily involved in decision-making. They can also stop things that you might want to do because they have different thoughts about it. And although community-driven vector control or integrated vector management was used in the paper of Maxine and Catherine as an example, so community-driven vector control, there are very few examples of where this has worked sustainably and successful beyond the funding horizon of projects, and very few successful examples are there. And that's why I put the question mark behind IVM. But why then this question mark? Why can communities not engage in and achieve malaria elimination as owners of a program? And there are, in my opinion, 2 important reasons for this. The first is best explained by looking at Maslow's pyramid of the hierarchy of needs. And the idea behind this model is that the fundamental needs must be met before an individual is able to think about fulfilling needs that are higher up in the pyramid. What does this mean? You will not start to worry about the mosquito breeding site in the bush that is 2 kilometers away from your house if you cannot put food on the table for your family, if you do not have income to pay for school uniforms for your kids, or if you live in an area where armed militias are making life dangerous. And unfortunately, in sub-Saharan Africa, particularly in rural and remote areas where malaria is rampant, people are poor and finding themselves at the bottom layers of the pyramid. Their first, second, perhaps even the third and fourth priority in life is not malaria elimination. Their priorities are basic survival, food, shelter, and safety. And this begs the question how we can expect these people to drive elimination of a vector-borne disease, notably malaria. So as a result, if we project the community engagement levels that I've just shown you over the pyramid, one can understand that the best that we can get from communities in many parts of Africa is consent and compliance. People saying, yes, go ahead, and people having a small contribution to your program. And that is actually what we see out there in the real world today. We see NETS and we see IRS as two of our main strategies to combat malaria. But any level higher up in the pyramid, more intricate, becomes more complicated. Even getting pregnant women to participate in IPTP or in future ensuring that children receive 4 shots of RTSS or seasonal malaria chemo prevention, as I'm showing here, will not be easy, let alone having communities higher up organizing and executing elimination programs themselves. People at the bottom of the pyramid cannot be asked to take on tasks that are at the peak of the pyramid. The second reason why this may not work as owners, communities being the owners of elimination programs, is the fact that most people in endemic countries have been with malaria all their lives. For many, it is simply a part of life. And although people would love to see the disease disappear, like all of us, it is there and people accept the risk that it brings. Asking such people to hammer down malaria to the last case is very likely not going to work. And again, for a perfectly understandable reason. If people see malaria disappear and there are hardly any cases left, people move on. People shift their priorities and tackle other challenges in their lives. They don't bother about malaria anymore. At that time, though, malaria is still there. It persists in very, very low numbers, but it may come back over time with a zero net gain. Whole governments have failed to eliminate malaria in their country because they considered it over and done and did not want to spend more money on detecting the last few cases in their communities. And that last mile, and this is significant again, that last mile in malaria elimination is the most difficult one and also the most costly one. Going from 100 cases to 10 is fun. Going from 10 cases to 1 is hard. Going from 1 case to 0 is hell. And leaving this in the hands of people that don't see the necessity and the need for rigor in operations anymore is a sure recipe for failure. Lastly, people often are willing to live with the risk and accept that they may fall victim to a disease. If anything, the COVID pandemic taught us that wearing face masks and keeping social distance was a perfect way to almost eliminate the annual wave of flu virus, the normal flu. It was hardly present because people were wearing masks. Yet, as soon as we no longer had to wear face masks by law, people stopped using them immediately, in spite of proven benefits. And the question is, why? It's simply because they are willing to accept the risk of COVID that lingers on in very small numbers, as well as the flu. I mean, Jocelyn was just giving the example of smoking. In spite of people knowing that it's bad for the health, people are willing to accept the risk that it brings. And the same phenomenon actually applies to malaria. The last point that I'm making here is much more fundamental. And that is that at present, we do not really know what the package of tools looks like to eliminate malaria anywhere in Africa. So if we don't know how to eliminate malaria in sub-Saharan Africa, how can we determine what the role of communities will be in this? This is very difficult. Today, nobody knows what the best package is for countries in the Sahel zone with seasonal transmission, or the rainforest belt in Central Africa with intense perennial transmission, or the eastern and southern savanna regions, or the highland regions for that matter. If we don't know what we will do, how can we determine what is best in terms of community engagement? And I therefore cannot conclude otherwise than in a very reserved manner and in more general terms that community awareness of whatever we do and will do, followed by communities agreeing with what is planned, community consent, is absolutely vital and essential. Whatever tool we will be using in whatever setting, we will be using them. Asking for compliance, sleeping under a net, is desirable and wanted, and participation will be great, but there is a but. As mentioned, when we do over-reliance on communities to participate in the last mile of elimination, that will be very difficult and might even be tricky. We may fail. And finally, handing over the responsibility for the last mile to the community in terms of ownership is highly likely to fail because motivation in that community will wane over time as cases become fewer and fewer and far in between. So what this calls for is a system that is more hybrid in nature, where highly trained teams, professionals that conduct vector control operations, similar to what we did successfully in the past, work with and alongside communities to eliminate malaria together. But at the same time, when the community gets tired and no longer sees the need and the necessity to continue, it should be these brigades that hammer the last nail in the coffin of malaria. And I'll leave it there. Thank you very much for your attention. Over to you, Leo.
But thank you so much. I found it a highly stimulating discussion, and I'm absolutely convinced that all our audience members enjoyed it as much and maybe even more than I did. So, you know, those are perhaps uncomfortable questions or statements, observations to many people, but critically important insights, wisdom that comes from many years of you know, working with people in those settings where the various challenges of reducing malaria burden and trying to move towards the ultimate objective of elimination are being experienced. So wonderful presentation, but good questions, good observations that we need to ask ourselves, what can we achieve by way of the communities, and what is unrealistic, and the things that we as well-meaning NGOs or the ultimate agents of authority, governments, what are their responsibilities at the end of the day to finally reach elimination? There are some aspects you can ask the communities to help with. There are some things, many things, you have to shoulder yourself. So very, very helpful and important insights there. Thank you, Bud. So before we go to the question and answer session, because we've reached that point now, I'd like to mention that APMEN recently prepared a substantive advocacy piece with the title Community Engagement for Vector-Borne Disease Control in Asia Pacific, Tools, Approaches, and Lessons from the Asia Pacific. It's a substantial document, and they're in the final stages of crossing the T's and dotting the I's, and it will be uploaded on the apmen.org website within the next couple of days. So if anyone is, you know, as I'm sure all of us are interested in community-related issues, This is a good advocacy document with case studies and distilled lessons and insights in there on the APMEN.org website. By Monday, it should be up. So again, as a reminder to our audience, please pose your questions in the Q&A box, not the chat box. And then we've got some pre-submitted questions, which I'd like to put to our panel of experts first, if you don't mind. So, Suparat, there's a question here. Is it correct to state that our core expectations of local communities basically come down to two requests? First, please use your bed nets. And secondly, if you have a fever, please go see your village malaria worker or the nearest clinic. Those are the fundamental issues that we would like communities to do. Is that a simplistic perspective, or does that kind of sum it up? Your opinion, Suparat?
Oh, well, you know, we can actually see into two case scenario talking about bed net where when you actually high risk of, you know, getting bitten by the vector, the main vector, like, okay, what is a habit of the main vector in that area? Probably much more at night in Thailand, but in Cambodia, they have the evidence that the Anopheles also biting during the daytime. So you see this kind of things and how we actually is going to promote. That's because that's when they actually high risk and getting bitten by the mosquito. Are they actually stay outside the bed net? And what kind of the most appropriate preventive practice and acceptable practice that they actually can do? So I think, you know, like go back a little bit to see that how we can actually promote and then to be really effective. Not just only bed net alone, when we're talking about how to prevent, you know, or how we actually practice against mosquito biting. So that would be the choice of it or something like that. And then for the health-seeking behavior, you know, when you get fever, please come to the clinic quickly and then get tested for malaria. The experience in Thailand that all the malaria endemic area, they have a very well set up of the clinic, the malaria post, the malaria clinic or something like that. So we even have many cases actually cross the border come to get the service in Thailand. So it's actually show that is actually quite acceptable. So people who actually have the fever, we have some pilot study I done with Jeffrey here many years ago. We found that the length of the time that you once they get fever until they actually come to seek healthcare is actually just a few days. Yeah. So it's not like waiting for a week or something like that, unless they go to the forest for a few days, they could not come back yet, or they are in Myanmar and they could not cross the border to come back quickly. So people are actually quite aware, and then they see that, you know, the benefit of going to the malaria clinic is not that difficult at all to go. And then once they go, they can get tested really quickly because the government plan, you have to get it done, everything within 19 minutes. And, you know, they follow the policy. So I don't know if I answer your questions, get carried away always.
No, thank you for that, Suparat. Thank you for those responses. So, Jocelyn, if I can move to you. But very well explained what was being asked by the particular question that I was going to pose over here through that Maslow pyramid of needs and so on. You know, that if you were to go around in a rural area that's endemic for malaria and you ask people, despite them getting malaria frequently, or family members getting malaria at regular intervals, what are the issues that are your top of the pile? What are the issues that keep you awake at night, that you lie and worry about? you know, consistently, as Bart pointed out, malaria doesn't even feature in the top 3. Malaria may come up around number 5 or so. You know, it's issues of you know, having enough money to put food on the table, buy clothes for the children, etc. So malaria is an issue that you get malaria, you recover from it, and life moves on. But chronic poverty, as Bart pointed out with that Maslow pyramid of needs, is something that's with you every day. It dominates your everyday life. So to ask communities to go the extra mile is usually unrealistic. So I want to ask you, Jocelyn, Bart made some very provocative statements there, and you know, put that series of steps of from complete disinterest to what you're doing, to consent, and then engaging with whatever you're being promoted and so on. Do you agree with that? The core message of what Bart was talking about? Or do you have reservations or qualifications that you would like to add to Bart's core message? Any comment from you, Jocelyn?
Thanks, Leo. I think it's important to understand that you know, that our presentations are linked, and that they're talking about different aspects of a similar challenge. And so I want to, you know, just further clarify that, because this may be new for some of us, but increasingly public health programs, including elimination programs, are recognizing the importance of using a behavior change theory to guide both the analysis and the application of insights from community members to inform our programming. And I think you know, that's relatively recent, and still the overwhelming majority of community engagement and community and SBCC initiatives do not use a behavior change theory consistently all the way through, from designing the formative research to analyzing and applying the findings. So that's very important. And I think you know, none of the solutions that we're talking about today, you know, there is no silver bullet, right? So we need multiple approaches and best practices to succeed. So I think it's important not to think about these recommendations as exclusive approaches, but rather to, you know, to understand that the key takeaway for me is that while there are no silver bullets, you know, surely neglecting to understand, you know, put the community's needs and preferences at the center of all of our programming, that is a surefire, you know, barrier to progress and to success. And there are tools that can help with that. A behavior change framework is highly recommended, and ideally a behavior change framework that includes the social as well as the individual factors that are required. I think that's really important. The only other thing that I would add on this point is that, you know, when I think traditionally we as vector control and malaria experts have gone to communities to understand what matters most to them, and why malaria is not top of mind. Again, as I mentioned in my remarks, we're often coming from the challenge with a relatively narrow health focus. That's because we're public health practitioners, so it's understandable. But you know, human-centered, people-centered, community-centered means first listening to and understanding what's important to them, and then thinking about how we can, you know, frame the vector control solution in terms that will resonate with them. And those terms may not be linked directly to malaria or immediately to malaria, but indirectly, right? If what matters most is being able to provide for my family, then we need to help communities understand how correct and consistent use of vector control products can help them achieve that goal that's important to them, right? So that message might have nothing to do with malaria, or it might indirectly link to malaria, but not directly linked. So I think there's a lot to be said for using our deep understanding of the needs and preferences of communities at risk to inform our programming, and that includes a deeper understanding of what many of us in the private sector refer to as the value proposition of a given solution. And that solution might be a set of vector control products and related behaviors. Thank you.
Yeah, thank you for that, Jocelyn. I suppose at the end of the day, you know, we have to remember it's those people, impoverished people with minimum resources, sitting out in a rural village or scattered about in individual dwellings across the landscape. They are the ones that are suffering. And, you know, they have limited abilities to help themselves. So at the end of the day, it's, you know, it's a collective effort. People can help themselves to some extent, but they also need government or you know, capacitated organizations to lend a hand. It becomes a collective effort. You need clinics and hospitals to diagnose and treat. You need formalized programs to distribute nets and do IRS. But you need communities to actually use those nets and so on. So, you know, it's not one or the other, and one has to do everything. We all have to join hands, and we'll have to learn and understand and agree how we achieve that. What is the optimum collaboration to achieve the optimum outcomes? So thank you for that, Jocelyn. But just a random question to you. Given your experience in both public and private sectors, governments decide and provide the policy framework for malaria control and elimination, and in most countries, they implement the practices to achieve control and eliminations. NGOs and others play a supporting role by and large. Given this stalemate we find ourselves in globally, the stall in malaria burden reduction, at least in Africa. In Asia, we've been fortunate in you know, getting closer to the ultimate goal of malaria elimination. Africa is a different ballgame. Do you think there's a merit in considering a bigger role for private sector? Oil companies, for example, they get allocated large blocks of land who then extract the oil for private profit, and a share goes to government. What about malaria? Can we divide the country up into blocks and open it up for commercial birds to undertake malaria control? It happens to some extent already where big mining companies operate, like Ashanti Gold, and they achieve massive successes in malaria reduction. Goodbye Malaria in Mozambique is another big success story by way of the Nando's mediated private sector malaria control interventions. Is it worth considering privatizing malaria control? I know that's a bit of an extreme ask and comment, but you know, private sector is often better motivated, capacitated, and has somehow the ability to get the job done. Do you have any comments on that, Bart?
How much time do you have? Lots of comments on this.
Not 1 minute, not half an hour. So
sure. Let me go back to a question that you posed before, and that you said, so what keeps you up in the middle of the night? And let me first address that, because that actually, you know, then fills into the question on the private sector. What keeps me up at night is the fact that we are living in 2023. And if I go to a lot of websites of NGOs or even UN organizations, I read that by 2030, we're living in a world without malaria. Let that sink in. We have 7 years left, 7 years left to get rid of malaria in sub-Saharan Africa. Some websites say 2040, but ALMA, the African equivalent of APMEN, ALMA says it's 2030. 2030, malaria is gone from Africa.
Wow.
And I would argue that if we do not start learning how to eliminate malaria, and I alluded to that in my presentation, if we don't learn what the package should look like in the north of Nigeria versus what it should look like in central Congo versus what it should look like in Malawi, then I think we are losing precious time to figure out how to do it. We simply don't know. And as far as I've recently had meetings with WHO, with the Global Fund and the Gates Foundation on this, where we discussed this point. Where's the package? Where is the package that I can say, okay, I'm now here in central Tanzania, this is what my package should look like. This is the tools that I bring together to knock malaria over the head and keep it down to zero. There is nobody in the world at the moment who has a solid, good answer to this question. Now that automatically, that is very difficult to decipher what the potential role of the private sector could be as part of this package, wherever that package is going to be rolled out. As long as we have not learned how to eliminate malaria, it's going to be very difficult to say, this is private sector, this is government, this is communities, this is the role of researchers or whoever. It's very difficult to figure that out up front. I think a great example of where the private sector has shown very good responsibility and contribution to controlling vector-borne disease was, I should say, in the control of trypanosomiasis, tsetse fly control. Tsetse fly control is typically something that you do not put in the hands of individual farmers or individual people, because you have to have an area-wide approach. You have to cover terrain. You cannot say, I'm focusing on the house as a unit, which we can with IRS or with gnats. But we can't do that with trypanosomiasis control. It has to be area-wide. When I was involved in the program in Zambia, we were trying to eliminate tsetse flies from an area of 8,000 square kilometers. It's a large area. And we had 3 different ways of doing this. We had community engagement, community participation in putting out traps and targets against flies. We had government, so civil servants, doing the job, putting out traps and targets. And then eventually we moved to the private sector. We had a contractor, and we set it up in such a way that the civil servants were controlling the work of the contractor. After a year, what we saw is that the community covered 8 square kilometers, 8 out of 8,000. Okay, we saw that the civil servants covered around 1,000, and we saw that the contractor was over 4,000. So basically, by putting the pressure on a paid entity, on a contractor, the private sector, and saying, here it is, go out and do this. And ultimately, it's the farmers, the communities that are going to be the beneficiaries, but you just take the responsibility out of their hands and let some outside entity do it. Certainly for trypanosomiasis control was a big, massive step forward. The question is, how do we translate that now to malaria? Something like, a completely different setup. And I think that going back to what I said before, in the 1970s, we did this when the Garki project ran in the north of Nigeria. It was a WHO-backed program with the aim of bringing a package together of tools with the goal of trying to eliminate malaria from the northern part of Nigeria. And it failed. And a lot of people say the Garki project failed. No, I would say the Garki project made us learn. That's a completely different thing. Failure should be seen as part of success. And we are now, these days, we are afraid to fail. And I would say we have to go out and develop the models, including the levels at which communities can be engaged on how to eliminate malaria. And we don't do this, and we need to start doing this very quickly. Thank you.
Yeah, thank you, Bart. Wonderful insights and comments there. Perhaps I just have too much of a bias in the power of private sector. But anyway, so Suparat, coming back to you, dengue is another mosquito-borne disease that is of concern here in Asia. Of course, it's in South America and in Africa, but in Asia, it's of more direct relevance to this particular group of people participating in the webinar today. It differs from malaria in that most of the Aedes breeding sites in urban and peri-urban areas are created by humans, and here it is essential to involve communities more directly and substantially in vector control. Do you have any experience in community involvement in Aedes control? And what is your perception regarding Aedes control by communities, such as waste management of empty tins, bottles, old tires, or the use of guppy fish for mosquito control? Is there strong community receptiveness and uptake of what they can do to reduce the dengue vector burden? Any comments, any experience you have, Suparat?
Okay, just very short. Benefit. If they see the benefit, what they are doing, they will do. And the way they do, what we suggest them is easy to actually digest and uptake. For example, if now we have the recycle program, really easy because they're gonna get the money, they're gonna sell the secondhand tires, lying around the backyard. That's all the source reduction. They see the benefit, and then the truck is coming. I'm gonna sell it now, so that doesn't make any difficult at all. And in terms of control the larva at home in the water container where they use every day. So that's going to be another way that you're talking about how people actually supposed to do the way they do. When the government suggests, you control the larva at home or something like that. But once come into the community themselves, they leave the community to do it by themselves. And how we actually make sure they're actually doing that. So from my experience, maybe I tell a bit that, I done the survey in 2005 that I published the paper in Khon The water container, which is the use of flushing the toilet, is a key container. And then how we gonna actually demolish it because it's built-in container. Okay, I just go to talk to the people in the municipality. I said that, in the future, can you make a plan that we don't build this one anymore, but suggest them to use the plastic bucket because it's easy to turn over and clean. So gradually, that kind of key container has disappeared, probably in the phase of about 10 years. But this is actually, from our observation, from our research that can suggest to the policy. Because, when we talk, okay, can you control this? What else we can do in the short term, in the medium term, and in the long term? Make it easy. So now I think in the area where we done the research, most of the house actually already have, it's like the flushing toilet, not the latrine anymore. So the key container has moved to some other container now. So again, this work is like a process. It's not like a one-stop service. We find something, we try to solve it, and go to find another one, also try to solve it. It's just a dynamic and process just like that. I hope that I not carry away again.
No, that's useful. Thank you. I like that example. Yeah, don't build a cement big 50-liter tank to hold water that you scoop water to flush the toilet. Just use a bucket that you can flush the toilet and then turn it upside down and have a tap that you can, fill the bucket next time. So a very practical solution. Jocelyn, I'd like to stay on the dengue issue because, you know, in Asia, we're very fortunate in that we're actually making real headway towards approaching that 2030 target that Bart was talking about earlier on. And even before then, 2027, you know, over large areas of Asia Pacific, we may actually reach malaria elimination. But dengue and other arboviruses, but in particular dengue, are on a steep incline, and it's becoming a genuine public health issue. So you working with communities in different, you know, public health related issues, do you get a sense that communities are taking on board, becoming more conscious about the risk, the threat, the need to engage more on dengue-related issues, and more importantly, government and NGOs even? Is dengue rising in the public consciousness? Any observations from your side, Jocelyn?
Thank you, Leo. I'm not sure how to respond to that question without referring back to one of the points from my slides, which was just to highlight that, you know, communities are incredibly diverse, and so it's hard, you know, and I would caution us from making too many blanket statements about community needs or preferences. At least I'm not comfortable doing that, but I will say that I think there are a number of implementing partners in working with more targeted and specific communities with us on today's call, who are definitely seeing that as the burden of dengue is high and maybe even going up in some contexts, and the number of malaria cases falling, it's natural that that at community level discussion about dengue may be greater than discussion about malaria. But I think, you know, again, it really comes back to, you know, what are the motivations and some of the conversations that we've been having about the perceived severity of an illness, one or multiple, as well as the motivational factors that are driving prevention or care for a given illness. So tough to answer in blanket terms. One thing that your question makes me think of, Leo, is that, you know, in some circles and some programs that I've worked with, I have seen a movement away from messaging that is malaria or dengue specific, and a move toward speaking about how to prevent mosquito bites. And I think that is something that I know the Vector Control Working Group has talked about in other forums, and think it's worth noting in today's session as well. I encourage all of us to again revisit, whether that might work. Thank you.
Yeah, thank you, Jocelyn. I mean, it's not just dengue and Zika and chikungunya. There are the Culex-borne ones as well, West Nile virus and Japanese encephalitis, etc., etc. So maybe it's better to start targeting mosquito-borne diseases, or, you know, bites, our exposure to being bitten. So, but before we move to the audience-generated questions, can I ask you one last question? In Asia, as I said, we've been very fortunate to bash down malaria to close to elimination levels. But Africa, of course, is a very different story, and I have to unfortunately agree with you. 2030 is probably a totally unrealistic target date for continent-wide elimination. So, you know, we're in for the long, well, at least a longer haul than just the next 7 years. Where do you see the major advances will take place in terms of malaria control, in terms of vector control? What will be the primary strategies and tools to get off the current plateau that we've been on since about 2015, where malaria reduction kind of flattened out, and we seem to be struggling to resume the dip that is necessary to bring the malaria burden down to elimination. Is it new generation bed nets? Is it attractive toxic or targeted sugar baits, vaccine, gene drive, mass drug administration, or just plain and simple a combination of all of the above and just persisting? Any observations from you, Bart?
Very difficult question, and lots of different aspects in this. In any case, I think in more generic terms, what I consider to be a major flaw in the way we're doing things at present is that if we're looking at what is happening in sub-Saharan Africa at the moment, what we see is that our strategy is commodity driven. In other words, we go and we hand out nets, or we go and we spray houses. I mean, this is basically commodities. We go and we have RDTs available in local health facilities. I believe that one key step forward is to move away from being commodity driven and to become strategy driven. So in other words, again, back to what I said before, we need to figure out how to treat malaria in any given context in sub-Saharan Africa. And Africa is a huge, massive continent with so many different settings that all require tailored approaches if you want to do it well. And that includes tailoring the role of communities in that specific setting. So that is one, moving from commodity driven to strategy driven. I think another thing that needs to happen here, and I'm sure I'm going to upset a lot more people, but is that we have to move away from chemistry to more sustainable approaches. I find that there is a great statement that Einstein made. He said, if you do what you did, you will get what you got. And this is so true with the way we are approaching malaria, where we have a problem with resistance to a particular class of insecticides, then we just hunt for a new class of insecticides. And basically we're staying in exactly the same treadmill, and a few years down the line, we find ourselves in exactly the same situation. And we start hunting again for a new active. Or, as is happening now, we're putting 2 actives on a net. And in the same way as we're going to be looking at triple medication, 3 actives in a pill, that in the next 5 years, somebody's going to come up with a net that has 3 actives on. And we'll say, this is the best way to break resistance from developing. And I can guarantee you, it's not going to still end up in the same resistance trap. So I would argue that we have to give more weight to the solutions that lots of people are working. There's lots of non-chemistry approaches in terms of vector control that people are developing at the moment. Give them the space, give them an opportunity to evaluate those new approaches to see if they can really contribute to malaria elimination and if they lend themselves for being adopted by the communities that we work with. So that's number 2. First, from commodity driven to strategy driven, and secondly, moving away from chemistry. The third thing that is a big issue that we just stick our heads in the sand and don't want to look at it is the issue of fake drugs. This is a massive problem. I mean, it's been estimated that this is contributing globally to 100,000 of the 627,000 deaths that we see. So in other words, if, let's say, ALMA or the UPLA equivalent, if we would adopt in their scorecards that proper drug regulatory boards are in place, that good laboratories are in place to evaluate the quality of the drugs that are coming into a country, and that we're not importing fake drugs or whatever, could make a massive contribution without us even changing anything that we do. We just make sure that the drugs that we deliver are good, properly working drugs. So the fake drug problem is a massive problem that could equally fast give us a big contribution and a big step forward. The next thing that I see as a really important way forward is that we should move away from randomized controlled trials that evaluate single strategies. This is a prerequisite now through the VCAC, the Vector Control Advisory Group of WHO, where we say, if you come up with a new approach in vector control, then we need at least 2 randomized controlled trials from different parts of the continent with epidemiological endpoints. The problem with that is that if I have a new tool, let's say the ATSBs that you were just talking about, that may just make a small additional contribution if I evaluate them singly in a randomized controlled trial, but if I combine them in a package, as we discussed, then suddenly that contribution may be much more significant than as a standalone tool. So I believe that the way we are evaluating new vector control tools that are coming through the pipeline should also be based on integrated packages and not just singular strategies that we evaluate. My last point, and again, this is a hot one. I believe that to a certain extent, malaria is very much in the hands of people like us, like academics, people building careers in academia, or researchers from around the world. There are lots of people in the US working on malaria, Europe working on malaria. We see that in the malaria world. We see where our people are, okay? And what we miss, what we certainly miss, is a lot more action on the ground, where people work under the hot sun to actually get rid of malaria and, again, learn how to get rid of malaria. Malaria is not something that you can just brush away with a social media campaign. I'm sorry, but all the fancy campaigns that we see, it's all nice, but that doesn't help you to get rid of malaria in the field. That requires different things. And what we're missing is a cadre of people that is out there actually hammering that disease down in the field. I think the Stevens Eye disaster that is unfolding in front of our eyes in the Horn of Africa shows us that what went wrong with Aedes albopictus, the Asian tiger mosquito in Europe, is repeating itself in the Horn of Africa. In other words, since 1990, we have not progressed in any way. We're still having the same problems. And I believe that the problem of Stevens Eye in the Horn of Africa is something that should be targeted by hundreds, if not thousands, of well-trained people that are out there in the field, that are paid a salary and that are day in, day out tackling this mosquito wherever it is, through surveillance and with whatever tools we have to do larval source management. This is the way forward. If we say that Stevens Eye should now be handed over to the hands of the community for them to get rid of this invasion of that mosquito in the Horn of Africa, I do dare to say, and I stand to be corrected 10 years from now, that we will lose the battle. So we have to start doing things in a different way. Thank you.
Yeah, no, again, I have to agree absolutely with you about, you know, very, very practical observations you made there about the value of, you know, practical lessons and practical approaches. There's a lot of practical experience and wisdom at ground level, get your hands dirty level out there in the field. Unfortunately, it seems that conferences and publications get better attention from donors, from you know, decision-making bodies and so on. So, you know, that's why the researchers, there's a disproportionate attention given to there's a need for better distribution of where the lessons reside, the wisdom resides, and so on. Point well made, point well taken. Thank you, Bart. So there have been a number of questions, several questions around the very basic issue of, and I'm going to direct this to Suparat. Suparat, it seems there's people would like to understand in the audience, you know, how do you go about engaging with communities? So let's try and generalize it. You know, can you in a very short few sentences, summarize, you know, what are the most optimal ways to engage with, to get messaging across to communities? Is it mass meetings? Is it approaching individuals at clinics and so on when they go to visit? Is it a collective way? All of the above? Any experience that you have, if you have limited resources and time, what is the best way to distribute a message or get the attention of communities?
Okay, thank you very much, because I also saw a few questions in the Q&A about how we actually, what is a technique that we first step into the specific approach to community engagement? I think the first of all is that you know them first. So basically, if you don't know, you don't have any prior knowledge about the community, you're gonna do rapid assessment first. Rapid assessment, characteristic of the community, or also what the health priority, what is their concern. This thing can be done really quickly. You can talk to the people, you can review the secondary data, or something. You get to know people. Okay, what is the length of malaria? Oh, probably number 10 or something like that. But anyway, after that, you can identify the stakeholder. Who can be the people that involved that can actually work together, identify the stakeholder, and then start discuss with them. This is the first step that we actually understand about the community and also start the engagement in the same time. So after talking to the community, you can use a snowball technique for them to encourage to talk to another person or something. And then we actually quite understand, see that the issue is actually become visible and clearer until you actually can identify again the stakeholder that you can, you know, find the time that you can sit and then talk together. And until we get the plan, now we go to how we're gonna do some activity about, like, for example, we would like to raise the awareness. What is the best place that you actually can get the awareness messages across? If you're talking about the health-seeking behavior of the mother, you know, to bring the under 5 to go to vaccination or to go to that, okay, where the mother, they're actually hanging out. Oh, every week they go to the temple to play. Oh, okay, that is the place that we're gonna go, or something like that. Oh, the best way is market. So because everyone go to the market. So this is just only some kind of example of the, you know, some technique that step by step that we actually can do. It depends on what target group and what kind of messages you would like to deliver.
Yeah, thank you, Suparat. So, you know, I've been quickly browsing through Jocelyn. Oh, there's Jocelyn still. We've kind of overstayed our welcome. We normally aim at 90 minutes. We're approaching 2 hours now, just 8 minutes short of that. So I think we need to wind down. The number of observations here about traditional beliefs and it complicates issues and how to deal with that. How to deal with, you know, as you make impact on the malaria burden and it starts going down, it becomes the point that Bart also made. The urgency of having to deal with the disease diminishes and people start focusing on other realities of life. How to maintain momentum on getting people to still use the bed net. You know, you can emphasize that it's not just malaria you're reducing by using a bed net, it's the irritant factor, etc. as well. So Jocelyn, do you have any experience in, let's take particularly the use of bed nets, because that's a perpetual frustration, it seems. You know, you can dish out free bed nets to people, but you will always get a fraction of people that accept that net but don't use it. Any words of advice or any comment on that?
Well, I think we have to look at what's the why, right, that we are promoting. What are we what's the messaging that we're using to promote the use of that bed net. And as you mentioned, Leo, in many cases, we're talking about an illness that is not top of mind. So it all starts with understanding our target audience's perspective, and then using those insights to inform human-centered, evidence-based messaging. Top down, stop malaria and use your bed met messages don't work. And yet, if you do a canvas of the vector control messaging, the majority of those of what we're using, unfortunately, don't align with the best practices of starting with the community's needs and preferences. That there are also, it's important to emphasize that what works for one segment won't work for another. Bart referenced, flashy social media campaigns don't work. Absolutely not. There's no way one social media campaign address, a variety of different segments. That said, the messaging and the channel that works for a mother of 3 young children and a teenager are going to be very different. We have evidence in the greater Mekong subregion of teenagers who are now putting themselves at increased risk of vector-borne diseases because they are going into the forest. This sounds counterintuitive, but they are searching for the signal so that they can access their social media and other online entertainment. So again, the message and the channel, one size does not fit all. And I hope that, among other things, we've been able to highlight the importance of community-focused SBCC, which will look different from one segment to another. Even in the same country, even in the same province and community, there will be a variety of motivational factors that work differently for different subgroups. And that is complex to work through. But with this group of champions of vector control, I'm confident that progress is ahead.
Jocelyn, thank you for that. Whoopsie, I'm not quite sure what happened there now. Yeah. Jocelyn, yeah, thank you for that. So I think we've kind of reached the end of our webinar. I just want to ask Bart in closing, because we asked Suparat a question, we asked you, Jocelyn, we asked you a question. Let's be fair and ask Bart a question as well. General question, Bart, is everything, malaria is an expensive business, so it requires a lot of money, and every year in the World Malaria Report, they indicate the shortfall in financial support for what is necessary to get the job done according to the projected plans, etc. So just your sense, Bart, in terms of donor fatigue, and there's disproportionate reliance on a relatively few sources of income. So we said that, or I think we agree that 2030, perhaps in the case of Africa, might be an unrealistic target date. So if we're actually truly aiming at 2050, what is your sense about financing, sustainable financing? Do you think, at least for the medium-term future, we're okay? Or are we going to hit the wall with serious challenges in the medium-term future? Any comments on that, Bart?
Yeah, thanks, Leo. This is a very important point. Let's start by saying that we have something between 3 and 4 billion a year globally to spend on malaria, and there are various estimates, but some people say that we might need as much as 10 billion a year to do a proper job. So clearly, the world is deprived of the resources that it requires in order to do what we could do. That's one. So But I would ask a fundamental question. Why does everything, when we're talking about what we call the developing world, why does everything have to be cheap? We have diseases here in the Netherlands, rare diseases, where the treatment of a child is costing €250,000 per year. One child, €250,000 to deal with a rare disease. And we do that. We spend that money on one child. Why is it that as a global community, when we talk about healthcare in Africa, that everything has to be $1 a person a year? Why? I'm asking a very simple, basic question, and I never get proper answers to this. Why does everything have to be cheap? And especially if we're talking about elimination, because elimination is the end game. Once you've played the end game, your payback over time is always going to be positive. So an upfront investment, a heavy investment in the tools that are required to hammer malaria over the head is surely a good thing. I mean, economists have made calculations that every dollar that we invest in malaria is giving us a return of $6. So clearly investing in malaria elimination is a worthwhile cause. So then the question becomes, is there money? Yes, there is an awful lot of money in this world. I'm using always the COVID example. Here in my country, in the Netherlands, when COVID hit the country, the government pulled out 80 billion to keep the corporate sector afloat during these difficult times. 80 billion was there on the table in no time. So there is an awful amount of money floating around on this planet, except that we don't seem to be capable of channeling it to our cause. And the question is, why is that? And then that comes to the point that you just raised on donor fatigue. And I do see this. I do see this happening. And I therefore believe that what we need to move into, especially with regards to 2030, 2040, 2050, whatever, is that we have to demonstrate to the funding community that we can eliminate malaria from however small that part is in Africa, where we go in, we work with local entities, we work with communities, we knock malaria over the head and we keep it at zero. An example like this will bring an enormous change in the way that the funding community is looking at us getting rid of malaria. Success will trigger people to spend more money on something that is successful. But if we continue like we're doing, where since 2015 we have not made any significant progress globally with our figures, especially in sub-Saharan Africa, then sure enough, people are going to lose their interest. And they're going to put their money in agriculture, in education, lots of different other things where people put money, but not in malaria. So we have to get success. We need success, showing that we have the tools, or we employ tools that bring us down to zero, and we keep it there. And with that, we go to the international public health arena, and we say to the world, look, we can do it. We have done it here. Now give us the money so that we can repeat it over much larger areas. And once we do that, you will see that also all of the investments that we need in terms of finding new drugs, finding new insecticides, once you've knocked malaria over the head and it's gone, you don't need to worry about that so much anymore. It is the problem of control that always means that evolution is catching up with us and we end up with resistance. Resistance to drugs, resistance to insecticides, again, again, and again, and again. But if we knock it over the head, we don't need to worry about this. So successes on a small scale to demonstrate that we can actually do this is going to be critical to sustain funding for our cause. Thank you.
Yes, thank you for that, Bart. What a wonderful set of panelists, to Supara, Jocelyn, and Bart. Wonderfully stimulating webinar. And on behalf of all of us in the audience, everyone listening in, we're very grateful. I'm going to ask our panelists. We didn't get to all the questions that were listed in the Q&A box. We ran out of time. I'm going to ask if you would mind if we forward you those residual questions. And if you happen to have some time, maybe you could respond and send it back to us, and we will distribute because we have the email addresses of everyone just under the email address. So I'm also going to ask the audience, please give us a few minutes of your time. It's not a few minutes, it's 1 or 2 minutes, just to fill in the poll questionnaire that will be on your screen. And then again, to our 3 panelists, a sincere thank you for your time. It was a very stimulating webinar, and we thank you, and we thank our audience members. And I'd like to thank Dr. Pon, Popo, Wulan, our technical specialists for making this webinar run smoothly. So thank you to everyone. Have a wonderful day. Thank you so much.